Welcome, everybody, to the Heart Valve Society interview series. I am Hector Michelena from the Mayo Clinic. I'm a professor of medicine and a cardiographer and valvular heart disease specialist. And in this series, we want to connect with experts in our field, valvular heart disease, to discuss fascinating topics and share valuable insights. Before we dive into today, I would like to remind you of the benefits of becoming a Heart Valve Society member. Our annual membership offers a host of exciting stuff for you. So be sure to visit the website of the Heart Valve Society to learn more about how you can join and get involved. We're also thrilled to announce, obviously, and it's kind of just about to happen, that our next annual meeting will take place in April in Cairo, Egypt next week. So if you want to go, there's still time. Now it is my pleasure to introduce our guest for today, Dr. Philippe Pibarot. Dr. Philippe Pibarot and I have been friends for many years, and I know very well of his work that he did initially in conjunction with Dr. Dumenil. And he has made tremendous contributions in the area of aortic stenosis, particularly the area of understanding low flow, low gradient, and understanding paradoxical low flow, low gradient for aortic stenosis, which is very important nowadays. So he's our editor-in-chief of the Journal of Heart Valve Society, and he is a professor titular of the Department of Medicine and head of cardiology research at the University Institute of Cardiology and Pneumonology of Quebec. So our topic today is hot topics in aortic stenosis. Welcome, Phil. How are you?
Thank you, Hector. Thanks for having me. It's always a pleasure to chat with you.
Yes. So let me ask you the first question. If a clinician, if one of us looks at an echocardiogram and the flow is normal, the flow through the LVOT is normal, and the patient has a normal ejection fraction, and there's no suspicion of low flow anywhere, American guidelines recommend in those patients to go with just hemodynamic parameters, meaning mean gradient and Vmax, and not necessarily look so much at the valve area.
True.
And I agree with that. But there comes a point where valve area is critical to look at, and it is because valve area, and you'll correct me if I'm wrong, is because valve area is, at the end of the day, the one that clues you in the most that this may be a low gradient state, particularly in patients that have a normal LV function. Is that the right way to see it?
Yeah, absolutely. I think, you're absolutely right. Often when you have what we call a discordant grading, it's when you have, a gradient and peak velocity that are non-severe, moderate, or even sometimes mild, but the valve area and the Doppler velocity index are severe. And most often this discordant grading occurs because of low flow state. So a discordant grading, a small valve area in conjunction with a low gradient is often, the consequence of a low flow state. Why? Because the gradient, we all know that, is highly flow dependent. And when the flow is decreasing, the gradient will tend to go down to become pseudo-normal. And to the opposite, the valve area is less flow dependent than the gradient, but still, remember, the numerator of the continuity equation is the flow. So it's a linear function of flow. So when the flow is going down, the valve area will become smaller and so become eventually pseudo-severe. And so this is where indeed we need to, especially if the patient is symptomatic, we need to confirm, we need other tools to confirm the severity of the stenosis. And you know, they are different type of low flow, low gradient cases, you know, that I'm gonna show soon if I'm able to open this.
Yeah.
You see, I think this illustration is a good one because it shows you see I'm going to try to go in slideshow mode, but um, um, so it shows that there are actually three type of low gradient AS with discordant grading. Low gradient AS will not be a problem if there was no discordances among the echo parameters, right? But here we have a discordance. So we don't know with the resting echo if the stenosis is severe and valve replacement might be indicated, or non-severe, and then conservative management is the way to go. And there are three types of low gradient AS. So you mentioned in the introduction, you have the traditional, you know, high gradient severe AS. And I agree with you. This one is a no-brainer, you know. If you have a high gradient, high peak velocity, you don't need to look at much other parameters, you know. Whether stenosis is severe, patient has symptoms or reduced EF, it's a class 1 indication for valve replacement. Let's go. But we know for a long time that we have people who have reduced EF. When there is reduced EF, the people understand that you often have, you know, low flow state because of the impaired systolic function. And if the flow across the valve is reduced, you may have this low flow, low gradient pattern with a small valve area and a low gradient. And none of the parameter at rest can tell you if the stenosis is severe or not. And in fact, this is what we call the classical low flow, low gradient. And if you want to make, let's say, an analogy or a parallel with heart failure, this is the HREF form of AS. And then you have
This is the heart failure with reduced ejection fraction
exactly.
for
Yeah,
severe AS.
this is the HREF with AS. We don't know yet if it's severe or not because we need to confirm the stenosis severity. You know, it turns out that 60% of these patients in the end are true severe, but there is still a 35% that are pseudo-severe. So we'll need to do, for example, the W-time stress echo in this case to confirm the stenosis severity. But you have this category that is even more challenging. This is the patient with preserved EF. And despite the preserved EF, they have a reduced stroke volume in the LVOT. So that is defined in the guidelines as a stroke volume index less than 35 ml per meter squared. So that's why we call this entity paradoxical low flow, because this is low flow despite preserved EF. And because they are in low flow, they may have the same, you know, pattern and mode of presentation as those with classical low flow low gradient, this discordant grading, and you have a low gradient, maybe despite the presence of a severe ES, you know. And then there are some patients who have normal flow, preserved EF, but still have the discordant grading. And these one are difficult. Most of the time it's measurement errors, but sometimes you need, you know, CT calcium score to confirm stenosis severity. So, and actually, why we call it paradoxical low flow, it came from this paper. So, and Hector, I can tell you, this is my best research and discovery journey. We all have, you know, in our career, you know, a paper we are proud of. And although this was a retrospective study, but published in Circulation, this started because, as you mentioned, you know, Jean Duménil was a very good friend and was my mentor. And he came to me and said, Philippe, there is something wrong. I'm every day at the Echo Collab, I see those patients and, you know, they have a small valve area, so you say, okay, it's severe, but then you look at the gradient and it's really not impressive, low gradient. And if I look at the valve with my eyes of experienced echocardiographer, I'm sure the stenosis is severe. But if I send this patient to the cardiac surgeon at the time, you know, he will laugh at me and say, well, preserve the F. You cannot have a severe ES if you have a preserved EF and a low gradient. Because in the mind of the people, it was before the HPEF was, well understood, etc. It was, preserved EF equals normal flow. And vice versa, reduced EF equals low flow, which is not true either, right? We know that patients with preserved EF, with reduced EF sometimes have normal flow because they have large ventricle and no MR. So same here. And so we say, okay, so we carefully reviewed this series and found, well finally, 18% of the patients had this paradoxical low flow, low gradient severe AS, and this was associated with worse prognosis. So, and then it started, and then we did several studies. But of course, it generated controversy. And I remember Jean Duménil was telling me, Philippe, it's a novel concept, okay? We've managed to get it published in Circulation, fine. But before it gets accepted, every new concept, especially when it's really novel, it takes 10 years to be accepted. So be prepared. And actually, it went faster. We discovered in 27, and actually it went in the guidelines in 5 years later. And a class 2A indication still, and now, recently, at least in the American guidelines, the strength of the indication has been raised to class 1 now, okay? So, and I think the reason why it went relatively fast in this case, twofold less the time that Jean had predicted, is because people were seeing that, and they knew it existed. But before you were trying, oh my God, I have a small valve area with a low gradient preserved DF. Okay, let's try to enlarge the LVOT diameter, and make it concordant, please, but still, the patient was symptomatic and not doing well and having a diastolic dysfunction and HPEF, and you say, wow, so, and then the people realize, okay, you may have a low flow despite the preserved EF.
I think it is important to then clarify for our audience that the low flow with low ejection fraction is the state of AS with systolic heart failure, and the paradoxical low flow AS is a state of diastolic heart failure with preserved ejection fraction and aortic stenosis. Is that correct?
You got it exactly. And I have this illustration here. Yeah, indeed. Again, we have assumed for a long time, it's not anymore the case, that, patient with preserved EF, aortic stenosis or not, had normal flow, But there are many reasons that may lead to low flow state in a patient with preserved EF. As you mentioned, the diastolic dysfunction. When you have, a pronounced concentric remodeling, which is often the case in patients with AS, they have pronounced concentric remodeling, especially the women. That's why this paradoxical low flow, low gradient is more frequent in women. So they have these small, thick ventricles, plus diastolic dysfunction. So small LV and diastolic volume, impaired filling because of diastolic dysfunction. They also have impaired longitudinal function, although LVF is preserved. And this may lead to reduced forward flow, as we see in HPEF. Plus the fact that often in this patient, you have AFib that contributes to the low flow state. That is one of the important causes of paradoxical low flow, low gradient. And name it, mitral stenosis, maybe less frequent, but MAC, mitral regurgitation, tricuspid regurgitation, and not to be forgotten, cardiac amyloidosis, that may represent about 15% of the patient with paradoxical low flow. And as soon as the flow is reduced, despite the preserved EF, you may have this low gradient, discordant grading entity, and you are in trouble. I mean, you need to do more because you cannot adjudicate the severity of the stenosis just with the rest echo.
Yeah. So I think a message that is important for our viewership is that concordant severe AS, meaning valve area less than 1 with mean gradient more than 40 with normal ejection fraction, is has a better prognosis, okay, even though it has a higher gradient that you would think it's more severe, but has a better prognosis than the paradoxical low flow situation, where you have a low valve area and you have a gradient that anybody would say this is moderate AS. And it
Exactly.
turns that you're dealing with a patient that cannot generate a higher gradient because they are in diastolic heart failure. And I think that this slide that you're showing is very important for our viewers to look at all the clinical factors and all cardiac factors that are involved in the genesis of paradoxical low flow, low gradient.
Absolutely. And Hector,
Yeah.
I think, the reason why this patient with paradoxical low flow, low gradient, especially in the earlier studies, had worse prognosis than the patient with high gradient AS was because they were undertreated. Because the severity of their stenosis, especially in women, because you're not very impressed by the gradient. So it was underestimated. And several studies have shown that valve replacement was underperformed. And of course, if you do not do an aortic valve replacement in someone who has a severe stenosis, you're going to pay the price, right? And this will have an impact on outcomes. Nevertheless, in several studies, including in the partner trials and others, we did some analysis showing that if these patients with paradoxical low flow, low grade finally undergo valve replacement, TAVR or SAVR, well, they have the same outcome as patient with high gradient AS, interestingly. So meaning that they benefit of valve replacement. The only subset of patients with low flow, low gradient who actually have worse outcome versus the high gradient AS is the patient with a classical low flow, low gradient and the low EF. This one, they are kind of, despite the valve replacement, they do not as good. They are probably a bit too far. So yeah, absolutely.
Yeah.
And
So
you see, this is the an example. I think it's good to show a typical example. That's the typical patient with paradoxical low flow. You will see 82-year-old woman, often again more prevalent in elderly women, with often concomitant hypertension because this contributes to the concentric remodeling and the LV diastolic dysfunction. She is, in functional class 3 HF. And LVF is clearly preserved. I did not show the apical 4 chambers and 2 chamber, but LVF is okay. Strain longitudinal is reduced. This is typical. She has grade 2 diastolic dysfunction with increased EO very prime, increased filling pressure. This is typical. You see all the hallmarks of HPF here. And if you look at the valve, and you see it is not looking good. You have this the 2D parasternal lung and the en-face view, shows a lot of calcium and restricted opening. And if you look at the hemodynamics, valve area 0.64, this is severe. Make sure to index for body surface area, also severe. Doppler velocity index that I always use as a safeguard, to kind of quality check for the measurement of the alveoli diameter. Because, for example, if I have a valve area that is severe, but the Doppler velocity index is not severe, so more than 0.25, say, meh, there might be something wrong. I have to double check maybe I underestimated the alveoli diameter. And we'll discuss that after, because the alveoli diameter is definitely the crux, in the measurements. And you see, there is a gradient that is not very impressive. And I have to tell you, in 2007, when we kind of described this entity, it was difficult to get a patient like this operated by a surgeon. They would say, 26 millimeters of mercury in someone who was a preserved EF of 65%. The stenosis cannot be severe, Philippe. And so, and you understand the reason for the discordance. Look at the stroke volume index, 29. This patient has low flow. And in fact, this patient cannot have normal flow. Because if you look at this very small ventricle, even 60%, well, my point is that 60% of nothing is still nothing, right? 60% of a small volume, a small LV and diastolic volume will give you a small stroke volume and therefore a low flow state, you see?
yeah.
And this patient actually, what we did and what is now recommended in the guidelines, not dobutamine stress echo. You don't want to do dobutamine stress echo, in a patient like this, with a pronounced concentric remodeling, you may have some side effects, and you will probably not be able to increase the flow. So we did a calcium score by non-contrast CT, easy and fast.
So
And
this is a very important point. This is a very important point because we use the low dose dobutamine hemodynamic stress for low flow, low gradient with low EF to try to determine if there is left ventricular reserve.
absolutely.
Left ventricular reserve, then the gradient will increase and we will confirm the severity of the AS. But I see you do not recommend doing dobutamine with preserved ejection fraction. And I have to say, I've done it a couple of times with patients that not this type of patient that you just showed with an ejection fraction 65 to 70% and an LV and an LV that's a little whole. No, but with a patient with ejection fraction of 54%, no hyperdynamic, the LV is not small, and I strongly suspect paradoxical. I have done on them dobutamine and documented that indeed it is severe.
Absolutely. We even did a paper on the potential usefulness of dobutamine stress echo in patients with paradoxical low flow, low gradient that we published a long time ago in JACC Imaging. But it was not the extreme patients, with paradoxical low flow, low gradient, such as the patient I'm showing now with almost no more LV cavity, and where you can increase inotropy, will not provide you more flow. And then we moved to when Marianne Clavel, my colleague and friend, went to the Mayo and did a fellowship with Maurice Sarano. She did a series of studies showing that in this patient, actually what you should do to reconcile the discordant grading is a CT calcium score, and this is now in the guidelines, both the American and European guidelines. It's a two-way recommendation to use CT to confirm the stenosis severity. This is really the way to go to confirm the stenosis severity in this patient with paradoxical low flow, low gradient. Dobutamine stress echo is a good test for the other group, the reduced EF, classical low flow, low gradient. Here, yes, and because it will give you more several information. First, eventually confirm the presence of a true severe AS, and second, as you mentioned, the presence or absence of flow reserve that has some prognostic value. But even there, Hector, with time and experience, we realized that many of the dobutamine stress echo we do in those with low EF, low flow, low gradient, often at the end are non-diagnostic because the flow reserve was absent or insufficient, and you're still stuck with discordant grading at the end of the dobutamine stress echo, and finally you go to CT calcium score.
Yeah. So CT calcium scoring might be the point breaker here to determine whether we're in the presence of something that's severe or not. Now, I want to ask you this because it bothers me a little bit, and it's a couple of questions. The first one is, you have on the definition there that ejection fraction is more than 50%, meaning it is preserved, right? Now, I have seen cases where, and I think this is where the importance of regular follow-up comes in, okay? I have seen cases of patients that present initially with a higher ejection fraction, higher gradient, and 2-3 years later, as you see them, you see that the EF declines is still above 50, and the gradient drops as well. And we were able to show that in our studies here from Mayo with Mac Elid and Patty Pellica. We were able to show those things. In addition, we were able to show that those patients, even though their ejection fraction is more than 50%, their longitudinal global strain was impaired. So I think it's important for the cardiologist and for the valvular physician to know that there is something wrong with the left ventricle. It's not that the left ventricle is completely normal.
Absolutely. I think, and the flow and EF generally, they go downward, and they don't. But the gradient and valve area same, I've not seen any valve area increasing, after a while, and back to normal. It's not a natural history, but the gradient may have, as you very well described, a biphasic response where it increases. And I have several of these cases where we were fortunate to have a long longitudinal follow-up with echo as well with CT. And we found that, we had, remember this patient, and she was a lady and she increased progressively the gradient and was in the 35, not far from the 40, and she was starting feeling kind of maybe a bit short of breath, but this wasn't clear, and then we continue to follow. And then the gradient start to go down. Oh, you may say, wow, improvement, great. The stenosis is stable, eventually regress, fantastic. Why we don't know, but if you look at the valve area, continue to decline, and the calcium score continue to go up.
Yes.
And this is because at a point, she reached the point where 35 millimeters of mercury for her was too much for the ventricle that she had. And
Absolutely.
and then the flow started to decrease. And the LVF width is same, while still being preserved, but it
Yeah.
was decreasing. And so it was contributing to decrease the gradient. Again, gradient is a squared function of flow. So if your flow is decreasing by only 15%, well, the gradient will decrease by 30%, So, and I'm with you, between you and me, I don't like this cut point of 50% that we have in the guidelines everywhere for aortic
Right.
stenosis. I mean, it's too low. To me, a patient with aortic stenosis, 55% is not normal. It's not normal. It's already systolic dysfunction.
Yeah.
And
Yeah.
typically in this patient, you look at the global longitudinal strength, it will be
Yeah.
down. And
Yeah.
and
It's interesting because it's the same phenomenon that we have shown for aortic regurgitation, that an
exactly.
EF less than 60% is a much more sensitive predictor of badness and bad prognosis for severe AR patients than the conventional, 50%. But this thing gets even more interesting to me because our studies here from Mayo show that the stroke volume index is not a fixed, single, discrete cut point.
As
People,
everything.
yes, people, yeah. So I think for our viewers that really want to know valvular disease, we have to understand that all phenomena in medicine and disease is a spectrum in general. But in order to make it easier for us to define and remember, we pick a random number, which is perhaps the best associated with it, but it's a little bit random. So what I mean to say with this is that we showed a spectrum of low gradient that went up to 40 milliliters per meter square and was still low. So I think it's important that if you have the suspicion that you are facing this entity and the stroke volume index is 37, that doesn't mean that it's not. It means that it likely is, and
Oh,
that you're
yeah. No.
within the spectrum.
I think, we are, responsible for this cut point that is in the guideline of 35 because this was the cut point providing the best sensitivity and specificity to predict outcomes. But you're absolutely right. This is a continuum. And I love this paper by Mac Elid, and your group from the Mayo, where he really showed that there is a continuous relationship and there is this nice line curve showing that the mortality risk increases progressively as the stroke volume index. And yes, around 35, 40, you have a kind of inflection point, and then it's increasing. The mortality is increasing more sharply, but still, and then we have not discussed the sex-related differences in our institution. We've shown that actually the 35 is maybe the best compromise for the world population. But ideally, we should use different cut point in men and women, which is, 42 in men and 30 in women. So big difference. So, and as the 35 is in between, right? But this was a simple way to go initially, but it's not the optimal way. I think we will discover more and more, and I think this is valid for MR, for AR, for AS, that we have to use different cut point for everything that we use. I understand that we need to dichotomize for clinical purposes, that easier. But we always have to remember that this is somewhat arbitrary and often same for men and women, which is wrong. Even maybe I will tell you the LVF cut point should probably be different in men and women as well. So it goes as far as this.
Yeah, that is fascinating. Let me ask you an interesting observation that I've seen many times. When all of this started and you started producing this fantastic knowledge, we realized that the prevalence of paradoxical low flow, low gradient severe, yes, varied from study to study tremendously. There were people suggesting that 30% of all ASs severe ASs that came to be seen were paradoxical low flow. While in reality is 10% or less, correct?
Yeah, absolutely. I think what happened, is that and that's typical, when people describe a new concept, now the people read the paper, find it interesting, and they tend to see it everywhere. Then, it was a bit like, at some point there was a big buzz around ischemic MR, and if you would read the paper at the time, you have the impression that there's more ischemic MR than primary MR, and same here. So I mean, there is maybe a overcall, of the entity, and the main reason is because it's very easy to create a paradoxical low flow low gradient. You just have to underestimate the LVOT diameter, and then you will make the valve area severe, so discordant in a patient with preserved EF. So really. And you know that very well, Hector. I mean, the LVOT diameter is really the crux, and that's the most difficult measure. That's the one that needs really to be well done, And before going to, CT calcium score and confirmation of AS severity, it's so important to do the echo right first. And because if you underestimate the LVOT diameter, and I can tell you it's so frequent, the underestimation of the LVOT diameter. And if you underestimate by only 1 millimeter, given it's squared in the equation, you're gonna underestimate the valve area and falsely conclude there is a paradoxical low flow low gradient, whereas in fact this is a concordant moderate AS. And so there are a number of things you can do to.
Yeah, let me share my screen.
That's perfect. That's a nice transition then. Hector, go ahead, please.
Let me share my screen and show you something that I have here. Do you see it?
Yes, perfectly.
So I think the point you're making that is critical for our audience to understand is that the LVOT is part of the calculation of the valve area, which is just a calculation. It's not a direct measurement by any means. That valve area is highly dependent on LVOT. You can see here a measurement of LVOT that is not very clear, okay, diameter 2.1 centimeter, resulting in aortic valve area of 0.9 centimeters square. When it was measured correctly, then it was 2.4 and the valve area was 1.2. And
exactly.
AS was not severe. And the critical thing, I think, for our audiences is that this area here is not well seen where they're placing that cursor.
Right.
Note at the clarity of how you're seeing the insertion of those leaflets right into the LVOT, and there's nothing black or hidden, okay? And you just put your cursor inner edge to inner edge, early systole, just at the point of insertion of the cusps into that LVOT. Would you agree with that?
I love this case. I mean, and really the recommendation, you need to first get the right plane, the right imaging plane that really open the LVOT, where you clearly have a good, as you mentioned, a good clarity, a good visualization of the entirety of the LVOT. Because if you have an imaging plane that is somewhat truncated, well, then you will underestimate. The other thing, and especially, the measurement that was to the left is measured a bit, too low in the LVOT. And you cannot blame, because if you look at some of the previous ASC guidelines, they were telling you measure 5 to 10 millimeter below. If you measure 10 millimeter below the annulus, in a patient with aortic stenosis, you're going to be on the septal bulge, because these patients with aortic stenosis, they all have this generous septum. And so, of course, and the septal bulge is something that is localized in the LVOT, and you're going to underestimate markedly. So you need to be really on the membranous septum, you need to be close or at the annulus, and you need to open this area, you need to see it. That's so true. Yeah, absolutely.
So I think it's important to recognize, as you mentioned, the clinical characteristics or clinical features that put a patient at risk for developing a low gradient, paradoxical low gradient EFI, and one of them is indeed atrial fibrillation. And atrial fibrillation, when you have atrial fibrillation, you have already a predicted survival that is less than the general population. Patients with AS and AFib have worse survival than AS without AFib. And one of the things that my dear colleague Vui Nakomo showed is that generally speaking, in patients who have severe aortic stenosis, but their flow state is low because they are in a fib, okay? We are usually measuring and averaging 5 or 10 beats, little beats of very little gradient, okay? And sometimes, many times, these patients will show this. There will be one of the beats where actually it does reach severe. And what was shown in this paper that was very nice is that these patients in AFib who had occasional gradients and peak velocities that were consistent with severe AS, and the rest of them were kind of lowish, okay, in AFib, when you looked at their calcium score, it was consistent with severe. And therefore now here at Mayo, what we're doing is AFib patients, we're not averaging 5 to 10 beats or anything like that. We are actually looking to see what the higher one is, and if the higher one is above 40, and we suspect a paradoxical low gradient,
Absolutely. No, I mean, I love this figure because you got it in a series of 4 bits actually. So the first 3 bits, you have low gradient AS, discordant grading. The valve area is not shown, but it's certainly small. And you're not surprised because look at the stroke volume index. On all these bits, it is way below 35 ml per meter square. But the one to the right, because it's a post long cycle, then better fitting, and then you have that's the Starling law, and then you have a higher stroke volume, and then you reach quasi normal flow, and hop, all of a sudden, then you reveal, you unmask the severe AS. It's like if you were doing dobutamine stress echo just on one bit, And I'm sure that if you would have done dobutamine stress echo, although it's not a good idea to do dobutamine stress echo in a patient with AFib, you would have probably obtained the same type of peak velocity that you have here, just confirming the true severe AS. But you don't need the dobutamine stress echo here. We've done also a study, well, a bit similar concept, but using from the resting echo, post extrasystolic beat, in patients with low flow, low gradient, because the post extrasystolic beat generally have a higher stroke volume, sometimes normal stroke volume, and then you can eventually, and we found that we were able to predict the gradient that would obtain at dobutamine stress echo. Interesting. But, I remember that your group and it was led by Patty Pellica at the time. Mark Elliott was the first author. And showing that you explored the different the prevalence of low flow, low gradient, paradoxical low flow, and the factors associated with low flow. And AFib was the main determinant of low flow. So I do believe beyond the concentric remodeling, the diastolic heart failure. Probably the most frequent cause of paradoxical low flow is AFib. AFib, for the patient for sure, but for the echocardiographer and the cardiologist, it's a troublemaker, right? It makes our life so much complicated. The measurements are more difficult. It is a cause of discordant grading, and then when we try to solve the discordant grading, everything is more complex. But it's so important, and yes, indeed, it is associated with worse prognosis, and it is a marker of advanced cardiac damage. I think we should intervene in AS and MR before AFib occurs, because when there is AFib, we've been a bit too far.
Yeah. So let me start going towards a wrap up. So these patients with paradoxical low gradient severe AS have a bad prognosis, so they need treatment with valve replacement.
Absolutely. So if you have a bona fide paradoxical low flow, low gradient, you did your homework, you verified, double checked the LVOT diameter, you got all your measurements right, and importantly, you found the cause or the underlying mechanism of the low flow. Because I have some fellow coming to me, they say, I have a paradoxical low flow, low gradient, Philippe, and fantastic, and then I'm trying to see, well, what is the reason for the low flow, the LV and diastolic volume is relatively normal. There is not too much concentric remodeling. It's not like the patient I showed you, preserved DF, no MR, that's still away the forward flow. No TR, no evidence of cardiac amyloidosis. The longitudinal strain looks good. So I say, hey, if you cannot explain to me why this patient has low flow, I will get back to you and saying this is a measurement error, and get back to the measurement of the LVOT diameter, LVOT VTI, etc. And multi-window interrogation with continuous wave Doppler, also very important. Absolutely. That we did not mention.
The other question that is critical is, do we need to do surgery in these patients with paradoxical low flow severe AS?
So
even if they are asymptomatic.
Okay, that's interesting. So first, it's a.
By the way, my answer is yes, but I don't know what you think.
Well, I think the first thing is to make sure it's a true paradoxical low flow, low gradient. Then keep in mind that you may have up to 40% of these patients with true paradoxical low flow, low gradient who actually have pseudo-severe AS, non-severe AS. So you need to have the CT calcium score behind to confirm that the stenosis is true severe. If the stenosis is true severe, I think I'm with you. I think valve replacement, TAVR or SAVR, whatever, is indicated. And I would say even if they have no symptoms, which is rare because, they are in HPEF. they have diastolic dysfunction. Most of the patients with true paradoxical low flow, low gradient, true severe AS, they are symptomatic. So it's not really an issue. But let's say that, you fall on the one that is asymptomatic still. This patient has some risk marker, at the advanced diastolic dysfunction, probably also some myocardial fibrosis, the impaired longitudinal strength, all markers. If you look at the BNP, it will be elevated. So you've got an argument to consider valve replacement, because in the guidelines for asymptomatic high gradient AS, yes, but you have, those, if you have very severe AS, or if you have markedly elevated BNP, or other things, you may LVF less than 60%, not 50 now, you may consider valve replacement.
Yeah, I think that's a critical point, that these patients are in a stage of diastolic heart failure, and most of them will have symptoms. However, there will always be the one who does not move too much, does not walk too much, and has not recognized the symptoms, no?
Right.
But let me ask you further. Do you think that all severe AS patients, let me get out of low flow, low gradient, okay? Let's talk about normal gradient, high gradient, severe AS, okay? You think patients that are asymptomatic need to be treated? Is it time to treat them? Or do we still need to be waiting for symptoms? Or do we still need to be putting them on treadmills and seeing what's going on, and so on and so forth? What do you think?
Well, with the evidence that have been recently presented, we have now 4 randomized trials, Recovery, Avatar. Well, okay, these were small trials, but then you had Evolve, that was also the powered, but then you have Early TAVR, that was well powered. And clearly, if you put all these trials together, and there's been a meta-analysis published recently, they show that, early AVR, TAVR or SAVR, is superior to conservative management in this patient, in all comers with asymptomatic severe AS. And so I think if you have the traditional severe AS with high gradient, peak velocity is more than 4, mean gradient more than 40, the valve is not looking good, I think you should intervene. And what we showed in Early TAVR, that if you do not intervene now, most of the patient will convert to AVR within the next year. And so maybe no need to wait, And the other thing is that if you intervene earlier in the course of the disease, the operative risk, and particularly the risk of perioperative stroke following AVR, is reduced. We showed that in the meta-analysis. It's not only a benefit in terms of unplanned cardiovascular hospitalization, heart failure hospitalization, left ventricular function recovery, etc., and quality of life. It's also, there is a positive signal with regard to the prevention of stroke, which is not a small thing, right? Stroke is almost as bad as death. So I think yes. So in the end, Hector, it will facilitate our work, because before we had to say, oh, okay, it's a severe AS, no question about that. But now, is there symptoms, and we're dealing with a population that is 75 years old on average, difficult to assess symptoms, and the sensitivity and specificity of the symptoms is really bad. And then, or is the LVF less than 50%? But, as we discussed, LVF less than 50%, probably already too low, even 50 or 55. So I think, yes, I don't have any crystal ball, what the guidelines will do, in the next year. I don't know. I have to commit, I would say, Hector. I would say, with the evidence, the meta-analysis, the 4 trials, I would predict that the guidelines will say valve replacement is recommended in all patients with asymptomatic severe AS and with a class 1B, level of evidence B. That would be my prediction. I may be wrong. So, and everything is recorded. So let's see.
Yeah, I mean, I just wanted you can see my screen, right?
Right.
Yeah, I'm just showing that systematic review and meta-analysis that you're referring to,
Yes, exactly.
which is relatively recent, and that's for our viewers to know. And the other one I was showing before is a TAVR
Yeah, it's
study.
the primary paper of early TAVR. Yeah, it's definitely a must read. Um, yeah, but the meta-analysis is good if you don't have much time because it summarized very well all
Of course.
the four trials and yeah, and gives, more power, especially when you get into events that are rare like stroke. If you don't do the merge analysis, you will not see the benefit, you see. So yeah, absolutely.
Yeah. So we're moving towards an era where the discovery, especially because we have TAVR now, and also because surgery, the risks of surgery continue to decrease over time.
Mhm.
We're heading to an era where having severe AS documented, well documented, it's not a question of when. It's not a question of are we going to treat you or not, or what? How many tests are we going to do? The question is, we will treat you, uh, and let's start planning for it.
Exactly. So I think, the most important is to confirm that the stenosis is severe. Uh,
Yes.
and even more after the next guidelines, once, because if it's a high gradient, it's a no-brainer, it's severe. If it's a low gradient, this is where you have to make sure it's severe. There's a little bit more work to do, as we discussed, about paradoxical low flow low gradient and all type of low gradient AS. And yeah, and then if we want to, talk about future perspective, there are some now several ongoing trials on at-risk symptomatic moderate AS, where we do the same type of trials, early AVR, early TAVR versus conservative management, but now in moderate AS. So maybe in the future, we'll also start to treat patients with non-severe, patients with moderate AS. It's not going to be all comers, okay, as opposed to severe AS, but it's going to be patients with moderate AS who have some risk marker like systolic heart failure or
Do we
diastolic
have
heart failure, low
do
flow
we have
stenosis.
do we have evidence of a trial in moderate symptomatic AS with those risk factors? Do we have data on that already or not?
Yeah, so there is only one trial that has been published so far. It's the TAVR Unknown trial, been published in JACC as well. And actually what presented at TCT and last year. And so this is not all comers with moderate AS. This is moderate AS with systolic heart failure. So reduced EF, LVF less than 50%, optimized heart failure therapy, and they were randomized to TAVR now, although the stenosis is still moderate versus conservative management. And so it's interesting because we had to change the primary endpoint during the course of the study because the recruitment was slow, then the COVID came in. And so because the recruitment was slower, we had more events, during follow-up. And so we revised the sample size from 600 to 300 and finally ended up with about 200 patients. So unfortunately, we were underpowered. And there was a trend for superiority for early TAVR, but it was not significant. However, if we would have looked or kept the initial primary endpoint that was at 1 year versus last follow-up when we changed it, it would have been significant. That's and the reason is because as in early TAVR, in TAVR Unload as well, many patients in the clinical surveillance arm converted to AVR. And so then, it's changing the natural history. And it's not like if the patient were randomized to clinical surveillance and they stay on clinical surveillance for the whole follow-up. They progress to severe and they need valve replacement. And so it's kind of, it muddies the water, right?
There was a lot of crossover in that study, you mean?
A lot of crossover. Yeah. A lot of, about 1/3 at crossover converted to AVR at 1 year. So this is why when you look at the endpoint at 1 year, it is significant in favor of early TAVR. But when you look, further during follow-up, you lose the significance. So I don't know what the guidelines will do with that. They may put, I don't know, a 2A or 2B. Again, we can do prediction for the patient with moderate AS and systolic heart failure only, because now there are two other trials that are ongoing, larger than TAVR node. The PROGRESS trial, that is early TAVR versus clinical surveillance with the balloon expandable SAPIEN 3 valve, and the EXPAND TAVR 2, which is similar design as PROGRESS, but with the self-expanding Evolute, okay, to the TAVR. And so they are ongoing, and these one are more not all comers, but it's moderate AS plus at least one risk marker, but could be reduced EF, but the majority is because of diastolic dysfunction, low flow state, AFib is one of the risk markers, symptoms, etc. So if you have one of the risk markers, you qualify. So it's if you have a patient with moderate AS that is doing well, there is nothing, the patient is not eligible for this trial. So we should have the answer in 2026 for PROGRESS.
Yeah. My last question to you: Do you think these last two trials that are ongoing with moderate AS and risk factors are going to show a survival benefit?
No,
of intervention?
I don't think so. Again, I think we'll show some probably unplanned cardiovascular hospitalization benefit in terms of heart failure, maybe also in left ventricular health, and quality of life, as we saw in early TAVR. But I don't think we're gonna, and maybe again, in stroke, when we're gonna do a meta-analysis, because stroke is always the issue of the statistical power to demonstrate a benefit. But I think in mortality, because still, even if this patient, in PROGRESS, early TAVR, and others are randomized to clinical surveillance, they are part of a trial. So they are followed carefully, If they do a little move, something, oops, it's reported. And so they will be treated in time. And this is where it differs from what happens in real practice. Because in real practice, if you're not, if you're not in a clinical trial and you see your cardiologist every year, and if you're lucky every 6 months, and they tell you, well, if you feel not feeling well, come back to me, and you're 80 years old, you're used to not feeling well, right? Just by waking up in the morning. And so, so then, yeah, it's a different story. So, I mean,
listen. I think we're running out of time. I would stay here another hour and keep on babbling here with you. But we have to close. My personal thought on those trials, those two trials that are coming with moderate AS, is that the survival benefit will be seen in certain subgroups.
For sure. And that's what we need to do in the asymptomatic severe AS trials, such as early TAVR 2, to do subgroup analysis. I agree with you. And maybe in the longer term, Yeah.
Well, listen,
Thank you so much.
It's been tremendous, Philippe. Thank you so very much. We're not going to bother you for a few months now. And to the audience,
always my pleasure. If you ask, I will say yes. You know that, Hector.
To the audience and to the Heart Valve Society, thank you for joining us in this installment of the Heart Valve Society interview series. We hope that the discussion was engaging and informative. I did. A recording of this session is going to be available in the Heart Valve Society website, so feel free to come and revise it, share it with colleagues if need be, etc. In the meantime, stay tuned for more interviews in the Heart Valve Society interview series, and we look forward to connecting with you again. Thank you very much.
Thank you so much.